My name is Richard Smalling. I've been tapped to take over for Dr. Peirce. Not that I am capable of doing that, but I'll give it my best to go. Everybody, looks like we have a total of 100% attendance, and that's wonderful. Congratulations to everybody. Our new member is Catherine Bissell, sitting to my right. Catherine, why don't you tell everybody a little bit about yourself?
My name is Catherine Bissell. I'm a nurse at Memorial Hermann Texas Medical Center. I also work as their chest pain center coordinator, and I abstract for Action Registry.
That was brief.
Yes.
So Catherine's a firecracker. She's got more energy than anybody that I've just about ever seen. So what I thought we would do is go over a little bit of an update on what's happened in STEMI that I know about, and then Lonnie will get us updated on action. So, how many of you got to go to the AHA national meeting? A couple. Well, at that meeting, Dr. McCarthy, our emergency room director, presented some data from the Action National Registry. I don't know whether Lonnie's going to go over it, but I'm going to just touch on some of the findings. Basically, what we've been talking about in this committee for a while is the importance of ischemic time on outcomes in heart attacks. And so basically a lot of this comes from MRI objective data showing that if you have over 2 hours of occluded artery time or ischemic time, the chance of having significant salvage diminishes rapidly. And what they found that correlated with better salvage was if you had a big infarct, so it's easier to measure an anterior infarct. If you got in very early in your symptoms, so we know about that now, 2 hours is really the magic number. If you have an open artery when you get into the cath lab, that portends a much better amount of infarct salvage. And what doesn't correlate is door to balloon time. So we heard in the previous meeting people ballyhooing about how short their door-to-balloon times are. What's happened is the National Action Registry data shows there's no correlation between door-to-balloon time and mortality. And in Michigan, they've had a dramatic decline in door-to-balloon time, but no change in mortality. So what this is telling us is we're not able to impact mortality just by shortening door-to-balloon time. We have to shorten the ischemic time. One of the thoughts about shortening ischemic time would be to give a clot-dissolving drug in the field or at transfer, and then taking the patients for immediate angiography. Pushback from the FINESSE trial and the ASCENT-4 trial results suggested that didn't benefit and may actually harm people. But when they drilled down on the FINESSE results, they found that patients who got half-dose lytic at the spoke hospital, at the referring hospital, and who had a slightly higher risk, had a much better, much lower mortality rate than those who came in for primary PCI, whether or not they got abciximab pre. So if they got, in this case, Redivase plus abciximab at low dose, and had a PCI, but they got the drug in the field, in the referring hospital, they did a whole lot better. Mortality was reduced by 50%. In the CAPTIM study, a study in France that randomized people to either getting fibrinolysis in the ambulance or being brought to the hospital for an immediate angioplasty, the mortality at 5 years was significantly less in those patients who were treated within 2 hours of onset of symptoms. So if you had chest pain for 2 hours or less and got a lytic you did a whole lot better than you did if you came in for a primary PCI. On the other hand, if you had chest pain for more than 2 hours, there was no difference in the treatments. Interestingly, you didn't get worse outcomes with fibrinolysis. You just didn't get any better outcomes. Oh, great. So this is one of the problems of copying your slides onto a jump drive. Well, what I'm going to tell you is in the CAPT-M trial, the shock rate on admission to the hospital was 2%. Was 0% if you got fibrinolysis in the field, and it was 3% if you just didn't. You got brought in by the ambulance. The mortality rate was about 2.5% versus about 6% if you got primary PCI. And at 5 years, the mortality rates continued to divide, so there was a 50% reduction in mortality in patients who got pre-hospital fibrinolysis. Not all the patients in CAPT-M went to the cath lab. Only about 20% went to the cath lab urgently. There's been talk about the danger, that it's more dangerous if you do a cath right after fibrinolysis than if you delay the cath for 24 hours after fibrinolysis. We now have actually 6 trials that randomize people to delayed cath versus urgent cath after fibrinolysis. And in all cases, there was a reduced death or reinfarction rate if they got immediate cath after fibrinolysis. Dr. Dinktis, one of my colleagues, published this last fall, basically showing 3 curves, one of which was the original Reimer and Jennings data, where they tied off the circumflex artery in dogs, and then after varying periods of time, released the occlusion and restored blood flow, then measured the size of the infarct with biochemical staining, and found this reduction under 2 hours of ischemic time to the left. Beyond 2 hours, the salvage, the infarct size didn't change much. The 2 other curves are MRI data and the fibrinolytic trialist data looking at improved reduced mortality with fibrinolysis. So all of these measures over the period of almost 30 years or more showed the same 2-hour window. In contrast, in the United States, in 2000, the average ischemic time was over 5 hours. And in the FINESSE and the ASCENT-4 trials, it was over 4 hours. So these are just increasing evidence, we think, that this is a bad idea. You all know that we've been giving pre-hospital fibrinolysis in Houston from 2005 or so till 2010, and what we found was a significant, very low mortality rate in hospital, and a low reinfarction rate, and a low shock rate on admission. We had to stop the trial for a variety of reasons in 2010, and this is what's happened. The in-hospital mortality with pre-hospital fibrinolysis was 2.8%. When we stopped it, it's now over 10%. Stroke rates were the same. In fact, fewer strokes in the fibrinolysis group. Major bleeding was the same. Reinfarction rate was a little lower. Shock on arrival, 2%, 2.5% versus 22%. So all this says, you know, gosh, maybe we ought to look at earlier reperfusion. And this is an assessment of the action registry data. And if you look at the top line, 23,000 patients. And then the second group is a paper Dr. Dinktis published looking at 1,600 patients with primary angioplasty for acute MI. And the mortality rate was 7.2% in the action registry. All of these patients were treated with primary PCI. And in the AMICO registry, it was 6.4% at 30 days. Shock on arrival, 10% in both groups. Reinfarction rate, 2% in both groups. If you look to the right, in our experience with the pooled registry of patients who got pre-hospital fibrinolysis, this was about 1,200 patients. In our PADCAR pilot data, the mortality rate ranged from 3 to 3.8%. The 3.8 is 30 days, the 2.8 is in hospital. The shock on arrival, 2.5 to 5.6, at least half what it would be if they didn't get pre-hospital treatment. Composite endpoint, is the reinfarction rate was about 0.5% compared to about 2% with primary PCI. So I think we have a substantial amount of data to push us to look at a strategy of treating patients in the field with some sort of reperfusion therapy before they get to the hospital. And this is something I think we need to think about this year. Is it possible? Can we do it? And how do we do it in Texas? So I just wanted to show that stuff to you. A lot of data, a lot of new data, and I think it will give us some food for thought. So Lonnie, why don't you go ahead?
Okay. Lonnie Den, American Heart Association, Mission Lifeline Initiative. I have a little bit of data. This ties in with what Dr. Smalling talked about, in that our delays to treatment we know are significant. Can you hear me? Is this on? Okay, thank you. And so, what are the ways that we can hit at that? I'm going to focus on DIDO times, or door in, door out times, for the non-PCI hospitals in this presentation. I think I only have like 14 or so slides, so not too much data, but the slides that with the blue background come from NCDR registry. They produce a national slide set every 6 months that they push out to all of us to use so that we can see how we're doing as a nation. These are with the data comes from the hospitals that are voluntarily entering their data. I want to say thank you always to those of you. I know there are many of you here that that provide data for the registry. And then hospital level reports come to each facility every quarter. So this is information as of December 2011. Here's the number of records that have been entered into the registry, climbing all the time, and I'll show you where Texas is in their contribution. I heard recently that North Carolina has always led in number of charts, patient charts that have been entered into the registry, but we're about to overtake them if we haven't already. So really glad for that, especially since we have a lot more PCI hospitals than the state of North Carolina. But in Texas, we're at 81 active participating hospitals. Wyoming, our little sister hospital up there, there are only 2 PCI hospitals in that state. One of them just signed on for their registry, so they're going to turn red in the next slide set. The approximate number of PCI hospitals in Texas, these would be hospitals that are performing PCI 24/7, really considered STEMI receiving facilities. We have 110 who have signed on with the registry, and then the 81 that are actively entering data. Some hospitals sign on with the intention of providing data and then end up not having the resources to support it. But that gives you an idea of the percentage that are participating. This slide shows door-to-balloon benchmarks for patients that are transferred in. So I think this is interesting to look at. So we're talking about the first door here. So the PCI hospital, or the hospital that doesn't have a cath lab or aren't capable of PCI, their first door, that's when the time clock is started, the data that's in this slide, and then the device or balloon within 90 minutes, and the percentage of time that's happening, and this is national data, and it's only like 23, now 28%. It's gone up a little bit, but we're still not able to meet that time goal very often. And then the first door to balloon within 120 minutes, so 2 hours, still we're only at about 59%. The goals for that transfer center, American College of Cardiology, American Heart Association in the fall, the ACS guidelines that came out recommend 30 minutes, in the door, out the door within 30 minutes. And then the Mission Lifeline benchmark for those facilities is we did a survey of facilities, and a lot of facilities that have refined their processes, we found that it's very, very hard to do that within 30, so we set our initial goal at 45 minutes. Can those facilities get that patient in the door, out the door within 45 minutes for at least 75% of their eligible patients? And then there's a current goal for facility goal to make STEMI ED door to balloon to first device time within 90 minutes. So that first medical contact, whether it's EMS or the outlying hospital. This is Texas data. This is how long folks are staying in those outlying facilities in Texas and in the nation. So it's not just a problem here, it's a problem nationwide as well. This is the percent of the time that they're making it from that first door, that referral facility door, to device. In Texas, 39% of the time, nationwide, 27% of the time. So surprisingly, I mean, Texas is a very rural state, so this surprises me, but I'm really glad. And median time within minutes, 102 and 110 nationwide. So this is something we looked at recently in GETAC, and this is publicly reportable data. It's found at Hospital Compare for the referral hospitals. Most of them are required to provide this data, how long it takes them to get a suspected heart attack patient in their door and out their door. And this is blinded data, but we looked at it by hospital in the region, and I just bring this slide so that you can see the variability of performance in the non-PCI hospitals and what opportunity we have to improve these numbers. So that first column on the left-hand side.
Lonnie, which is GETAC?
Austin region.
Austin.
Mm-hmm. So all the way to the left, average for all U.S. Referral hospitals, 60 minutes. Average for Texas, 60 minutes. And then the top hospitals are doing it within 40 minutes. And then the letters here are blinded for the participating or the non-PCI hospitals in the region. So we go everywhere from 30-some minutes up to 160-some minutes for those patients. That the dwell time, I think, is what Dr. Mixon calls it. And those that are not entering the data, there's our acute care hospitals and critical access hospitals. Some are required, it's mandatory, and for some of them, it's not mandatory that they report. So some are voluntarily reporting. And this is a slide I think actually I stole from Dr. Mixon's talk. But this is a great paper. It's what can we do? What are the processes you can change in your outlying facilities to improve? And in the newsletter, actually, that Scott and White puts out quarterly, I just received. There's extra copies up here. Dr. Mixon breaks that out into just kind of a step 1, step 2, step 3. What can you do to improve that process? I think it's really great. So I brought that. Along. And then just this is off topic, but last time I promised these field guides and I forgot to bring them. So help yourself if you're interested in one. That's STEMI field guide from one of the regions. And just going to finish up with a couple learning opportunities. I always like to let people know about things that are going on, conferences, ways that we can learn. This is the Concepts in Contemporary Cardiovascular Medicine Conference. It's in Houston. Dr. Smalling, Dr. Bailey do a great job with this, and they're doing an afternoon STEMI symposium on May 3rd. That's the Thursday of the conference. The next learning opportunity will be May 31st and June 1st. So that statewide conference that Dr. Mixon and Dr. Damer's team have put on in the past, and the Caruth Grant team from Dallas have joined forces. There will be one a statewide STEMI conference this year in Dallas at the new Omni. Last save the date, the GETAC Mission Lifeline team, being led by Catherine Bissell, are putting on a really unique conference. It's going to be September 22nd, and it's going to be very interactive. They'll have STEMI video simulations, really focusing on the STEMI processes and what you can do in the real world to, affect your quality and care. So I think that's everything I have.
So do you have a breakdown, Lonnie, on the patients that are transported by air versus by ground, and what does air transport impact for a given distance, whether or not the door one to balloon time is impacted?
We do have that data broken down. Just off the top of my head, the patients that came in through EMS, either air medical or ground, their first door to device time is greatly decreased. So come in by air medical or ground medical. Those that walk into those outlying facilities, there are much greater delays for those patients. But if the actual breakout, I can get to you. I didn't put all of that on the slides today.
So, Tim?
I'll comment on that question. It's a complex answer. It's one thing that we've learned. We've actually got a report that we're working on right now with one of our centers. And what we found in talking to other people around the state and around the country, it's dependent on a number of things. Number one, the distance that you're going to travel. A lot of people are traveling by air and they're going 20 miles or 25 miles, which usually is not enough to give you gain. Again, geographic variation if you're in Manhattan, maybe, but most places in Texas it's not. So I think for most places in Texas it's probably 40 miles or beyond before air would give you a distinct advantage. But there's a lot of other things to consider. We had a hospital in our region that actually had to throw them in a truck, take them a mile down the road, meet the helipad, put them in a chopper, as opposed to a facility that has a helipad right outside the ED. So there's a lot of considerations there, but as a general rule, it's probably overused because it takes a lot longer to prepare a helicopter to fly than it does to throw someone in the back of a truck.
Lonnie, I had a question. There's for this data, to collect this data, you have to go through, end up with an angioplasty somewhere. You start off with the infarct at the outlying hospital in say a rural setting. You go to a community hospital, you get transferred, and you end up in the cath lab, and that would be the complete capture in that data. We know that if you are in that community setting and you know you're not going to make it by 120 minutes, you're going to get lytic therapy. Are we tracking, or is anybody following? Is there any way we're capturing the data of those patients that the upfront strategy is lytic? Is that data being collected in any way at all?
It is being collected in action, and the specific lytic that's given is captured. In terms of like mortality rates being broken out, I have not seen that. I don't know if anyone else has.
The data Jamie reported was all primary PCI. The amount of lytic given is very, very minuscule, even pre-transfer.
Yeah. Well, I guess that's what I was thinking. It almost comes back to your point as far as moving the pendulum back to this. If we've gotten so far here where you just have to get into a cath lab facility, no matter how long it takes, and we know that through guidelines that are set forth, American Heart Association, is if you know you're not going to get there in 120 minutes, and you really should be giving lytics. And maybe that we need to start getting that chatter up, because obviously the dwell time here, you add that, and then you add there. There's some places that, for even our situation, not even going to be close. Now, obviously, you can improve processes and limit that, but it may be that, from a busy traffic time, and that you're 30 minutes in your emergency department, you add plus the transport time, it's not even going to be close to 120 minutes, then that strategy should be lytic up front as opposed to one size fits all for those patients that are on the hub. For those patients that there's no way because of the transport time, then they should obviously get lytics up front. And I don't know that, I just haven't seen that data because I've been so far in the cath lab and balloon and stuff. So
the guidelines do allow, if you can't get reperfusion within 90 minutes, to give a lytic, and they currently recommend reduced dose lytic based on the adverse events in Ascent 4 and Finesse, which have been debunked already. But the new guidelines should come out in the spring, and I think things will change. There'll be more of the pendulum movement toward upfront treatment. So we need to discuss what we want to do this year, and that's the next item on the agenda. And so, Robert, you sort of teed it up. If you say, well, we're just not getting arteries open fast enough. So one thing we probably ought to know is how many of the RACs in Texas have active cardiac committees? What's the penetration of interest in STEMI care and so forth? Lonnie, you probably have your finger on that.
Well, we haven't done a survey actually for several years. We did a survey actually through, I think it was the RAC chairs several years ago, probably 3 years ago. And we had, I'll have to look back at that data, but I think we had 6 that didn't have any, maybe more, that didn't have any type of committee at all. Does that sound right to you? Yeah. Yeah, I did. I don't remember anymore. Yeah. I know we have a significant uptake in the last couple of years of regions getting coordinated, just some really tremendous best practices out there. But in terms of like a definitive survey, it probably would be good to do that again.
So that would be number one, I guess. So we need to do a survey of the RACs for STEMI committees. And since you did that before so well,
I'm glad to work on that. Sure.
Yeah.
Can I add to that, though?
Yeah.
Because, in the Houston area, we've got a pretty active cardiac care committee, and I know there are a couple of other RACs that got pretty active, but, it's one thing to have a committee, and it's another thing to have a committee that's getting some traction. And I think that some of the RACs that we had discussed, Lonnie, last time, they were calling it their cardiac committee, but it was really sort of a critical care, included in stroke as well as cardiac, and maybe these are the less populous RACs. But, one of the things that if we're going to put forth this effort, not only find out who has a cardiac committee, but have they, let's come up with a couple of markers of how much traction they're getting. Do they have a compendium of who's, monitoring their door to blue times, and, are they reporting those back to the RAC? I mean, what kind of data exchange is going on? Because that's how you're going to get the traction.
Right.
So, Robert, you're the one that's done the survey. Do you have milestone suggestions for Lonnie?
We can go back and look at it. Lonnie, I'll help you with that.
Okay, good. So probably, I think that's a great point. Go ahead.
No, I think you're absolutely right, to get some substance behind it. So I think that makes sense. So we can find out that just because you put a sign up doesn't mean you're doing it. So we can look at that.
So data collection, guideline adherence, like if there is a set of protocols that everybody has agreed upon, education, if there are if there's education going on. I think that's a great idea.
Regionalized, if all the hospitals are participating, because some RACs, there is just one hospital or one main system doing all the work, and the rest of them aren't participating at all. And then in some other RACs that I've been to, smaller RACs, 100% of all the hospitals are participating. So the amount of participation in each region would be an important indicator of how well saturated we are.
So are the RACs, in those RACs where there's variable participation, are they also including STEMI referral centers in addition to STEMI PCI centers, or whatever the
Yeah, in
verbiage is?
most, I know in all the larger RACs, and I know in our little bitty CBRAC in Corpus Christi, it's 100%. It's every EMS agency, it's every run, it's every STEMI, every stroke, and every referring center and every receiving center.
Say that again.
It's all the participating agencies and
They
facilities
participate in the RAC?
that participate in the
Okay.
RAC are participating in the program.
Got it,
So,
okay.
so that would be important to know. Are the STEMI referral centers participating in addition to the STEMI receiving centers?
And EMS, the EMS agencies.
What I would propose is that everybody, when you're driving home or flying or whatever, think about it, and we'll send an email out and just fire us back with questions. We'll put it in categories of this makes sense. And also any ideas about the most efficient way to get these answers. I mean, when you see survey, a lot of people just delete delete. So if you have any great ideas on how to get this done in an efficient way, please put that on your email.
And there may be someone who can inform us. There was a survey of some kind that went out a couple months ago to the RAC chairs, I believe, and I'm not sure I didn't see it. I don't know what questions were asked, but during public comment time, maybe if someone knows more about that.
Maybe Dr. Smalling will offer a free iPad or something like that for if you participate in the survey.
Welcome to the chair's seat.
Okay, the second item, I think I heard a motion that Robert made. Tim heard it as well. He's looking at me. That perhaps in Texas, we ought to have a recommendation that if a patient arrives at a STEMI referral center and cannot get the patient to a PCI, not to the PCI hospital, but to a PCI within 120 minutes of onset of symptoms, not arrival, they ought to get lytic.
So right now the guidelines are first medical contact to device within 90.
No. The
Well,
ACC guidelines are symptom onset.
first medical contact.
Okay.
But I think we're going to see that change. I don't know, but the new guidelines, the new STEMI guidelines, will be out, we hope, within a few months, and we'll see what the recommendation is at that time. If it will be if it'll be stated symptom onset to device, or if it will be first medical contact to device. So
I'm a little worried about opening up that box for a symptom onset, because as you know how hard it is to find, and in stuttering symptoms, and I mean I'd like to get some real work done. I'm afraid that we may get muddled if we.
Okay.
I'm a little concerned about that. So, I mean, do you guys have any other thoughts on that?
Tim, you worried about that?
Yeah, I'm worried about that too.
Well, what do you think?
I think we don't have enough level 1 prospective randomized data to say that yet. I mean, as you pointed out in your presentation, there is very tantalizing data, but every time we've actually studied it prospectively and randomized, we've been disappointed, perhaps for good reasons, as you pointed out. But I think until we get a little better data in that regard, we can maybe inch in that direction, but I don't think we can.
So door 1 to balloon time of 90 minutes or less? Or,
Yeah, I mean, first medical contact could be the EMS before
Okay,
that
fine.
referral.
Okay.
I mean,
do we have a consensus on that?
Can you repeat what the supposed consensus was?
I guess we're going to debate whether it's 90 or 120, because I think there's still a debate. I think in my mind there was a debate, but the first medical contact, so I'm saying an outlying hospital A, the EMS for that A picks up the patient in their bedroom with that would be the start. And that if you can't, from that starting point, get them their artery open within 120 minutes, in my mind, because I think that's safe, then they should be getting lytic therapy up front. Did I explain that correctly?
It sounds reasonable. It's
So
a start.
Is this a clinical care recommendation that we're making?
Yes.
Can we do that? State, can we do that? Can GETAC do that?
Okay, I think
As a physician, I'm in support of it. I'm just wondering as a bureaucrat if we can do it. Okay.
Okay, so
Okay.
let's repeat the recommendation to make sure I understand it. We are considering a recommendation for the state of Texas for every person whose first medical contact to open vessel time would be 120 minutes or less. Would
Or
have
more.
or more.
Yeah.
Would have a lytic given by EMS or a lytic given by.
It would at this point would have to be the transfer, STEMI referral hospital.
I think that's current recommendation already, is it not, Lonnie, in that 2010 update, that if you're greater than
It is.
90 to 120, depending on the patient category,
But
it's
we
already.
I think what Dr. Wozniak suggests, we start tracking it. It's a recommendation.
Okay,
we
so
need to
we're
track it.
talking about tracking,
Oh,
not changing.
Tracking. Oh, I thought, never mind. So it's not a critical care
Tracking
recommendation.
adherence to the guidelines.
It's tracking adherence, okay.
Okay, all right, I'm okay now.
How?
Lonnie's
How
nervous.
are we tracking it?
Huh?
How are we tracking it? We don't have any mechanism to track things as states.
No, but the RACs do. Theoretically, they're cardiac care committees.
They do. We are. I mean, the
Or
RAC
they
is.
should.
The RAC is, yeah.
Or they should.
So we make a recommendation that the RACs track this data and send it in. Send it up to Jane.
And so defining first medical contact, it's the paramedic face-to-face with that patient, or when that patient
It's a 911 call.
walks in the
usually.
referral facility.
It's the 911 call.
No, I think it's when it's patient context, it's when the EMS provider says, hello, my name is, what's your name?
Okay.
Yeah. Or when they walk through the door and they say to the triage officer at the hospital, the triage nurse, I've got chest pain.
I guess my only comment about this is the same thing. Comment would be about the survey, that you only get maybe one chance to do it. So of course we want to make sure it's very thought out. It's complete for what we want, but not too extensive. So in the same way as we're talking about, we want all the RACs to report back to us one piece of data. Is that really going to be realistic and efficient? Or if we really want to try to obtain data from the RACs, should we carefully consider, well, if they're going to do one piece of data, would 5 pieces of data be helpful?
Okay.
As opposed to kind of creating an entire network to report one piece of data.
You're exactly right. So we have a meeting. So we need, maybe one of our goals would be to formulate a set of data points we would like to have from the individual RACs on STEMI care.
Okay, one comment. This is already being done through the Regional Mission Lifeline Action database. So I think we're jumping ahead of ourselves.
I'm not sure if that's right.
Well, so for the regions that have all of their facilities participating in action, we will have regional reports through action that will come back. We can look at those mock reports, see if that will meet the needs of this group. But it's something that several of our RACs are moving to. I know Corpus Christi, the Austin RAC, has all hospitals participating, and they'll be able to they'll have a report that'll come back for the RAC. So I think to your point, Dr. Smalley, we take a look at that
Okay.
and see if that would meet the needs for those regions that are doing that, that are participating in that way.
I think this early recommendation may be better set for the more organized systems that can do that, as opposed to putting a burden on a system that they have a hard time just even getting name, rank, serial number, because you may find data in the systems that are mature and easier to collect system, a mature system here, easier to collect, that may be riveting data, and that would make it more an incentive for others to track.
All right. So how about, I think we need to percolate this and bring it back to November. So we'll leave it on. And so you, as Robert says, you guys think about that and let's formulate a plan. One other possibility is a communication from this committee to the local RACs on update in action registry, update in literature, maybe something from Caruth on, things that have worked in Dallas, give San Antonio a shot, things that work in San Antonio, Corpus, whatever. So maybe you two could put together a one-pager or something. Would that be? Who's going to pay for it? Do we have a budget for that, Maxie? Do we have a budget for that? No?
What a shock.
Richard, one thing that was brought up before was the dissemination of information that goes on in these meetings. There was expressed some frustration on the public comment part, and so if there's a mechanism in place, whether it be audio conference, anything where you could capture some of the essence, that may not be that hard when you talk about going out to each rack and having some type of a website that you could link in to download certain points that come up here. I think that we have to use technology, especially when you don't have money, maybe a way to do that. So perhaps we could do a video conference of you and summarizing our points at each meeting that they could click on or something.
Well, this is being transmitted, correct? And where is it being transmitted to?
It's streaming on the internet and it's also recorded.
And it's recorded. All right, and so we could then send a link to all the racks that they could put out, published among their members, email or something? Is there an email list of the heads, the local directors of the racks? And so that could be sent out. Could we make that as a motion, Maxine? So that the proceedings, the video of this meeting could be distributed to those that were interested in the local racks. That would be free.
Right, and especially if you're talking about assigning certain topics, those topics could be a link to. Tim is very good at cranking out things as well, I know, and you
Yeah.
probably already have stuff that maybe even memorialized in videos or audio conferences or something like that.
So links to articles.
Links or something, or some type of archival, something. So especially if you want to have an update, maybe even an update section or something. I'm not quite sure, but I think you already have the infrastructure here. It's just a matter of tapping our resources.
So is there a website, Max, that we could use that we could put STEMI literature of interest or something like that?
You can always put it on your website. Our website under your organization, under this committee.
Awesome. Is that all right?
What?
Do you agree with that? That we can vet the articles, everybody contribute ideas, and then we'll send them around to the committees and get a vote on at the next meeting? How about that? Would that work? Is that legal?
I guess what I would like at the next meeting, if we can go over the process, what is the process that we could use so it's easier for us to, if we have energy and creative, and what's the process? Where do we go? You get an audio file? Do you do a video file? Do you do an article? I mean, just going over the process, the steps to some type of education that was easily distributed. So that would be helpful.
Can I make a suggestion? Putting on my EMS medical director hat, one of the things when it comes to cardiac care that I find most useful, and I'm glad that Catherine is here because she participates in this, is that I get reports of our STEMI patients that I brought to some, but not all of our PCI hospitals in the Houston area. But the reports that I get back are incredibly valuable. And what might be good on this as a service is to give examples of how hospitals can report information back, because I've mentioned it here before, but I'll get reports back from hospitals. They abstract a bunch of data from our records. It's a lot of the same stuff that goes into Mission Lifeline, so it's not really duplicating a lot of work, but it has, the 911 time, our first patient contact time, when the 12 lead was done, when the 12 lead was sent, when the 12 lead was received, when they activated the STEMI team, when the patient arrived at the hospital, when they got to the cath lab, when the balloon was opened. I've got a picture of the vessel before the balloon, and I got a picture of the revascularized. I've got a copy of the EKG that we sent in, if they got one in the ER, and I can take that and I go back to that crew and I can sit down and we can teach them, and these guys, then they get it. That is true continuing education. Those guys learn, they experienced it, and you know what? Next time they have a patient, they're going to behave a little bit differently because of that experience. If we want rubber to meet the road and get some traction, I will tell you it's not a survey, but that is rubber meeting the road.
So, Dr. Pearce, would it be helpful if there were template, that if we were able to
Right.
house some
We'll even give
templates or
examples.
actual case studies?
I can give you examples because you know what? We've de-identified them. There's no, it'd have to come to me so that I can then match it with the stuff. But if you look at this piece of paper and pick it up, you'd never know who the patient was.
Yep.
So, and because you sent them to us, and it is incredibly valuable.
So, David, were you volunteering to share some of those
Yeah.
reports? And so maybe Catherine could help help with that?
Yeah, and we could put them on, however we're talking about getting this information out. But then the EMS folks in the room, the medical directors in the room, if you want to turn around and go to your hospital and say, hey, look, this is what, you know what else works great? Is if you can get one hospital to do it, you then go to the neighbor hospital and say, well, you know, Hospital A treats us really good, look what they do. And all of a sudden you'll have 2 hospitals doing it.
Who's the target audience? I mean, in your case, it sounds like the people who are the boots on the ground doing it, but is that where any of these educational
I can tell you for us, the whole STEMI team gets that piece, and it goes to the paramedics as well, to the EMTs. So everybody that does this work, that's on call for STEMI, whether it's cath lab or physician or whatever, gets that report. And so in our case, Catherine goes over, kudos, you know, door to balloon time, 8 minutes, you know, that sort of thing. Pitfalls or something, what's your other term?
Areas of improvement.
Areas of improvement. You know, the EMTs picked their nose for 30 minutes on site before they brought him in. I mean, so, you know, that's facetious, but that gives you an
But going
idea.
back to what you were talking about as far as continuing education, who's you're saying everybody from the administrators to the security to EMS to the doctors, to
No.
everybody is part of this continuing education audience.
Not in our case. Who's it go to?
Administrators, it goes to cath lab, it goes to the interventional cardiologist, to the fellows. So anybody that participated in that case, HFD, goes to their medical directors and then they disseminate it.
But I'm saying for this committee that we're talking about continuing education, who's our target audience? Is that
Well, we were talking about giving things that could be distributed to the RAC over the internet
okay?
or on our website. So we could maybe on the website say case of the week or case of the month or whatever, and put up a couple of STEMI reports. And everybody would be welcome to contribute. Austin, you guys, and so Corpus. And that way you could give examples. This is what happened in Corpus. You know, this is, you know, how they handled it in Austin and so forth. I mean, I don't know. It's free. Right. So you could have models that people could say, oh, that's like us.
You know, some of these cases are really, there are definitely learning points. Some of them are operational and systems and how you get, and others are medical. And, you know, it might be good if some of the, you know, physician members of this committee, if we had a case where we thought there was a real learning opportunity, one of us then go and, you know, do a narrative or a commentary about what the learning point is and, you know, something to make it an educational, it's too bad we can't get CE for it, but the registry would probably accept that CE back, never.
Why don't we lost one of our members, it looks like, so why don't we go around the table? Robert, do you have anything to add, any new stuff?
Well, you mean, are we winding down pretty much, or?
No, well, what I thought was we'd go around the table, open it up for public comment, and then sum up.
I'll just pass. I'll have nothing.
Okay. Karen?
Just a couple of comments on.
Yeah, slide it forward.
Just a couple comments on what we're doing currently with the Caruth grant. We're to the point now of making educational videos and trying to decide if that's going to best be served as the entire STEMI team, like we were talking about, or in addition to have the PSAs as well. We have several PSAs that are going on in the area right now with several hospital agencies are putting their heads together about, they're having not actual patients, but contrived scenarios where they're calling paramedics and getting to the hospital quickly. So I think that we can probably help provide some of those.
So you
things
could
as we
provide
go along.
material as well. So this,
Yeah.
so
Yeah.
great, okay.
And we are, like Dr. Purse said, we are starting to get reports, not in as much detail, but they are starting to call us and tell us, you know, this happened, it was great, and we are rewarding through the Heart Association, we're rewarding the people that have the best time, door to balloon time. So that's really evolving now. So we feel like it's something that we want to start sharing with everybody.
Great. Josie? Nothing. Lonnie, anything else?
I think this is a lot that we've talked about already. I mean, it's great.
No. Anything else you have
To add to it? No.
No? Chris? No? Catherine? Christine? Tim?
My comment would be, this has been a recurring theme, but it never goes anywhere, maybe because there's nowhere to go, but you were talking about public service announcements. You were talking about treating people early. You know, we can give them fibrinolytics within 5 minutes of seeing them, but if they're coming in at an average of almost 2 hours, which is where they're coming in, that is a problem. And I wonder, as advisors, whether we shouldn't at some point tackle that issue of whether we should be advising the state on patient education initiatives to do that. Should money be spent? How should it be spent? Because that's really the elephant in the room. You know, we are seeing STEMI systems improve, and we see pharmacotherapy improve, but you know, it's all for naught if they're way out, if they're already on the flat part of the curve when they come in, which oftentimes they are. We've talked about it, and Dr. Wozniak has been sort of an expert in this area, and there are certainly limitations, but I wonder if it's still not a worthwhile thing for us to try to tackle somewhere down the road.
So what we're looking for is spots in local media that could be used. So
I mean, it could even be, you know, we were having a conversation this week about this very issue, and people were saying, as you know, you've pointed out, that you can do PSAs, you see some change in behavior, but as soon as the PSAs go away, the behavior goes away. And my, I guess, theory is that it may take a generation, unfortunately, to see changes. So could this even percolate into the education system? I mean, should we be teaching in health class something about STEMIs? Should there be something that, you know, eventually gets into the curriculum so that when people are 45, they have a little better understanding of these things?
okay, so here's the thought. Each one of the committee is charged with identifying one local media person that they could put the pinch on, and say, is it possible for you to do some PSAs free regarding acute MI care, which kills 10% of the people right now, even in the best of places. So I'm going to see one of the local news anchors on Wednesday in the office, and I'll for sure take it to him.
Well,
So-
one of the things we're doing, we actually approached our local newspaper, small town paper. They're actually going to let us do articles monthly for free on cardiac care, and so that's the first 3 or 4 articles are going to be, you know, addressing that. I don't know if it'll be effective or not, but again, I guess from a committee perspective, I just wonder whether, I think you started out saying what should be our goals for the
Right.
year, whether we should explore that and ultimately we try to make some recommendation to the mother committee and to the state about how this is done, what should be done.
Okay.
And I'm going to just add on top of that, so this isn't identification of symptoms, but we do have American Heart Association advocacy team. One of their goals for this year is to get education in the high schools about hands-only CPR. So we're going to be really pushing for that. And so that's something we can do right now. If anybody's interested in helping and volunteering and going with our advocacy staff to visit with legislators about getting that passed so that we can increase our rates of bystander CPR in our communities.
We, according to our clock, we've got 13 minutes, but Max is saying we got to stop. The previous meeting went over, so we sort of cut back. Is there anybody out in the audience that feels the burning need to make a comment? Yep. Okay. Yep, public comment.
I'm Christine Reeves. I'm the Executive Director of Heart of Texas RAC out of Waco. And I would caution you to assign a whole bunch of stuff to the RACs until you've done the survey to know which RACs
Sure.
can get the information you want. Number 2 is, since there hasn't been any legislation to make this happen and all the RACs are doing it because it's what's right for the patient, that maybe you suggest that you have a RAC come and present what their STEMI program is. Because there are a lot of us out there that have full 100% programs, that aren't in Dallas, aren't in Houston, aren't in San Antonio. that are smaller areas.
So you're asking for people, volunteers, to come to your RAC to talk about success stories?
No, I'm saying maybe you should have a presentation by RACs that already have STEMI systems developed.
That's what I'm saying. But I mean,
Here at this committee?
Yeah, like we would come here and do it
Okay.
as a
Like,
presentation.
we would invite the Waco RAC to come present to us, because that would be a great idea to see what each of the capabilities and what they've already put in place. And we heard from Dudley, and they have a great system, but let's hear from some of the other guys and put them on our agenda for next time.
And I think that'll help because none of us have any money.
All right,
And so hearing how other people are doing it will be helpful.
okay, so if you could suggest folks that you know, that's fine.
Okay.
Okay, great. Next.
My name is Eric Gepley. I'm the executive director from STRAC in San Antonio. I would second what she just said. I think this group, one of the problems you have, one of your challenges is understanding what's a good idea for the state committee to do. Many of you guys sit on, this sounds a lot like a local committee discussion about PSAs, and you're sort of trying to find your way as a state committee. This is an editorial, so I probably shouldn't say that. I think one of the things that would be very helpful for this state committee for cardiac care to do is to go to the to start developing a statewide cardiac system exactly like we did trauma and stroke. There has been no enabling legislation to mandate, whether there's funding or not, just to mandate a statewide. We did it for stroke easier than we did it for cardiac. There's plenty of money to do this with. We just need to get the legislature to say we want to have a statewide cardiac care system. It's not in place. That will enable item number 2, which I would ask that you guys consider, which is multi-center. This data collection piece should be about how do we align data processes so that we can compare data across the multiple centers of excellence, and I don't mean centers in hospital, but I mean in systems of care. We don't have that today. Dr. Wozniak, we've had several conversations about ways to do this among the centers of gravity. The final thing I would ask is that you guys consider Dr. Peirce's idea. This is a best of breed sharing. Best of breed ideas. Rising tides floats all boats. I don't know to ask our one hospital. I agree with your point, by the way. All you got to do is get one to do it, and they're all following. But I didn't know to ask them for that good idea. Right? So if there were ways to share these great ideas among the regional systems, then we're making everybody better. So I think that's an opportunity of the state cardiac, and maybe that's part of what Christine doing some of those presentations will help with.
Very good. Thank you so much. We're going to have to close now. So, and I'm sorry. So Maxie's going to come beat us up if we don't get out of here. So thank you all for coming. I think we've got our marching orders, and we'll see you in November. Right?